I'm going to hand the mic to Sigall, who's going to talk more about the safety implications of this kind of transparency.
Fantastic. I'm Sigall Bell, and it's great to join everybody today, particularly in such a special week where we're honoring patient safety awareness. Thank you, Boris and Jan. Let me move us forward with some of the safety implications. I think it's been really exciting to see some of the momentum that has been generated around patient engagement as a safety strategy, with several key leading organizations recommending this as a specific approach. We see this with the NPSF and Lucian Leap Institute white papers on transparency and patient engagement, and also in the recent IOM, or National Academies of Medicine report on improving diagnosis in healthcare. But while there's general agreement that patient and family engagement in safety is a good idea and that the diagnostic process can be improved by engaging patients and families, it's been harder to operationalize this principle because we just don't have clear, systematic, effective ways of doing so. We think that OpenNotes can provide a tangible, scalable strategy for engaging patients and families in this way. And in this section, I'll share with you some of the safety data. Well, from the very beginning, back in 2010, with the study that Jan has shared with you, we began to hear many anecdotes from patients and doctors that pertain to safety and quality. I'll share a few of them here. First, we heard about follow-up adherence. This is a patient who says, weeks after my visit, I thought, wasn't I supposed to look into something? I went online immediately. Good thing. It was a precancerous skin lesion my doctor wanted removed. And I did. Patients also commented on medication errors. When I told her about the wrong issues, she admitted she confused me with another patient. Also, on one occasion, she made a statement about increasing the dose on a medication that I never took. We heard a lot about care partners, those individuals who help to support vulnerable, elderly, frail, or chronically ill patients. And here's a patient who says, it's really much easier to show my family, who are also my caregivers, the information in the notes than to try to explain it myself. I find the notes are more accurate than my recollections. Doctors commented on the benefits of more eyes on the chart. I felt like my care was safer, as I knew that patients would be able to update me if I didn't get it right. And they also commented on better notes. I had to have better documentation, which is a good thing. And many providers commented on dotting I's or crossing T's, comparing OpenNotes. In addition, patients and clinicians also commented about medication adherence, that patients were more likely to take medicines when they better understood the reason why they were being prescribed. One patient commented on notes as almost an additional person reminding him to take his meds. Many times we heard about patients better remembering next steps, getting from point A to point B by virtue of being able to read their notes. And the example here is one patient who comments about leaving a doctor's office after paying a lot of attention to all the discussion in the room and leaving and saying, did they say this or did they say that? It's like having this big amnesia after the visit. We even heard about low-hanging fruit issues like access to records. There was a patient who was abroad in Singapore when he fell sick and went to the emergency room and was able to access his OpenNotes by virtue of having the OpenNote availability, enabling his providers in Singapore to immediately understand the active issues and his correct medications. And so all of these anecdotes really prompted us to take a more curated and detailed approach to examining OpenNotes and patient safety through this initiative. And we were interested in 4 primary areas. First, can OpenNotes help close safety gaps or reduce ambulatory risk in the space between visits? Can it bring patients and providers closer together in that vulnerable space? Second, can patients find and report documentation errors in their notes? And will these be clinically meaningful? Third, can OpenNotes strengthen safety partnerships between patients and clinicians, activating them to be looking together for the safest care possible? And fourth, what are the effects on vulnerable populations? So let me start here first with OpenNotes and its effect on some ambulatory safety knowledge and behaviors. And what we're looking at here is a busy slide, but I will walk you through it. This is a survey that took place at 2 healthcare centers in Boston. And we're looking at the responses of 10,000 patients and family members regarding two specific ambulatory safety issues we chose to focus on, the hot button issues of referrals and tests or test management. We asked patients and families who had had referrals or tests in their actual care, so these were experience questions and not hypothetical questions. Has reading your or the patient's notes helped you to do a number of different things related to referrals and tests? The response categories were on a 4-point Likert scale, from not at all to very much. And we're looking here at the percents who responded quite a bit or very much. So as you can see in the top bars under referrals, reading notes helped over 75% of patients, parents, and caregivers to understand the reasons for the referral. Similarly, under tests, all three respondent groups better understood the reason why the provider ordered the test, with about 75% on average endorsing those opinions. Similarly, just jumping down a bar or so, about 75% of respondents were more likely to check their test results and to understand the test results. When we look at actual behaviors, remembering to go to the appointment and to get the test done, about 50% of respondents across categories reported that reading their notes helped them to complete referrals and tests. And taking the aerial view, I think there's two things that stand out here. One is that despite very different populations, patients themselves, parents, and caregivers, the overall trends are remarkably similar. The bars kind of track consistently. The second point to note is that even with such high endorsement from all patient populations, what stands out is those green lines, the caregivers, and the fact that access to notes can really help put a safety net underneath these 40 million Americans who are helping to support vulnerable populations and help, again, connect those dots or get from point A to point B, particularly when they can't make it to every visit. But what about documentation errors? Again, in this survey with 10,000 respondents, about 17% or 1,500 or so errors found at least one mistake in the note. An additional 12% or another 1,000 errors thought maybe they weren't sure. The types of errors they described, their symptoms, the health problem list, medications, and family history were among the most common. Of those who found at least one mistake, 44% said they thought the mistake was somewhat or very serious. But only about half contacted the doctor about this mistake, reminding us of the opportunity to better support patients and families to speak up about possible documentation errors or other mistakes in their care. Overall, 94% of patients said they were confident or very confident in their ability to find mistakes in the notes, demonstrating that patients are interested stewards of the medical record. Well, these data prompted us to take the next step, and rather than just ask patients passively to read notes, we invited them to provide feedback on the note through an OpenNotes patient reporting tool. The tool was built with two goals in mind. First, to engage patients in safety, and second, to offload providers. And the mechanism here was, rather than having kind of a catch-as-catch-can approach where patients would contact or not contact their provider or the clinic when there was something in their notes that was of concern, we generated a more formalized or systematic approach that flowed through our QI mechanisms involving the same flow or pathway for the kinds of improvements that we seek in accuracy for healthcare in our organization. What we found, in short, is that patients can and did find and report documentation errors. And we were really intrigued by this opportunity for the first time to really create a closed-loop system, sort of a classic safety principle, and a learning EHR, where in the past, notes kind of were signed, sealed, and delivered into the ether of the health record, but never really reviewed for accuracy. And here we had the opportunity to put them in front of patients and families and identify places where there may be problems that need correction. Patients really welcomed the opportunity to help providers to get it right and often commented on an enhanced sense of partnership. Here are data from the very first year of the reporting tool when it was piloted in a primary care clinic in our hospital. Over the first year, 260 reports were submitted by patients and caregivers, predominantly patients. And you can see that the great majority of patients thought their note accurately reflected the visit, 98% responding so. The great majority, 96%, also understood the plan of care. But for those few who didn't, we were able to circle back and help them with any confusion they had about next steps. Here's an interesting part of the reporting tool story. Over 3/4, 77% of participants volunteered positive feedback about the providers and their notes. And we began forwarding this back to providers, and something interesting happened where it generated positive culture change, where providers were hearing, perhaps for the first time, about the things they were doing well and not just where there were problems in care. Among all the reports, 22% identified potential safety concerns. And interestingly, even those respondents who indicated a possible mistake in their note, the majority also volunteered positive feedback about the provider, again underscoring this principle that patients wanted to help providers get it right. 98% of respondents found the tool valuable and would use it again. Here's the breakdown on the kinds of problems that patients were identifying in their notes. The greatest category was in medications, followed by past medical history or the problem list. About 18% similarly reported a problem in the description of symptoms or something important missing from the note, which in the era of interoperability challenges with the medical record offers a unique opportunity for patients to be able to fill in information that is missing. About 11% commented on problems with the physical exam, for example, parts of the exam that were documented but not done. And you can imagine how that might be the case with macro imports in notes where whole exams are imported but not necessarily done. And obviously with important safety implications should the patient then develop an abnormality that is not appropriately date or time stamped relative to the last normal exam. Some patients also flagged problems with family histories that had not been updated, including important information related to breast cancer or other screening changes that would take place if the clinician had known about that history. Each of these reports was reviewed by our QI team, and in total, about 2/3 of patient concerns were found to be possible or actual safety concerns. The majority of closed-loop reporting tool interactions where we were able to circle back with the patient led to a change in the record or in care. And the challenge with any patient reporting tool is really getting patients and families to use that tool, but what we found was a multifold increase in ambulatory reporting, in the rate of ambulatory reporting compared to our online adverse event reporting system used by clinicians in the same clinic in the same year. Well, here I've demonstrated just some examples of safety catches as a result of OpenNotes before and after the reporting tool. One patient found a recommendation for pulmonary nodule follow-up recommended by the radiologist, but found by the patient because it had been missed by the clinician, and she was able to bring that back to her provider. Another patient commented on the wrong provider listed on a colonoscopy report where the results were sent, and in fact, that provider was no longer in practice, so the results did not reach a practicing clinician. One patient commented on a note reporting new lesions on an MRI, but she in fact knew that these were old because she had a separate scan done at an outside facility in the interim. A caregiver noted that hyperthyroidism was listed rather than hypothyroidism, the actual condition. There were numerous reports of inaccurate medications or family histories or physical exams, as I've previously mentioned. In one note, no malignancy was written as now malignancy. In another, patient-declined PSA testing was documented when in fact the patient noted that he wanted it done. Some notes detailed plans for cardiac testing or lab work, but no requisition or referral was made, enabling us to close that loop and move patients forward in their diagnostic pathway. In some notes, wrong side documentation was noted. Some notes were entered on wrong patients altogether. And this is one of my favorites because it speaks to the parlance of medical note writing. Many clinicians will end the note with, discuss with patient who agrees with the plan, and this patient said, actually, I don't agree with the plan. And it was just a flag for us that, wouldn't you want to know if that's how the patient felt, so that you can come up with a plan that everybody can work towards together. I'm highlighting here in orange, just as a quick flag, that many of these reports and the kinds of information that was brought to us by patients have direct implications for the diagnostic process. Well, now the reporting tool has been live not only at our organization, but also at Boston Children's Hospital, where they've launched the tool across the house in all but very few, very sensitive clinics. And in addition, there's a third organization in the Southeast U.S. who's recently piloted the reporting tool, and we're seeing fairly consistent results, again, despite very different patient and family populations. So here I'm just highlighting that at Boston Children's, the number of reports with potential inaccuracies was 31%. Ours has held steady at about 22%. The kinds of problems, again, those top 3 or 4 seem to hold steady, with problem list, description of symptoms, medications, and missing information. And I think taken together, what these data show us is that patients and families can help, and our data add to a growing evidence base demonstrating exactly this same finding time and again. Well, let me shift our attention now to the effect on the doctor-patient relationship. And I think there was a lot of concern, particularly at the beginning when OpenNotes was first beginning to spread, that wrong, erroneous, offensive notes might harm the patient-doctor relationship. But what we found was that actually 99% of patients reported that they felt better or the same about their doctor after reading as few as one note. And when we went back to look at those patients who felt better about the doctor, the 37% with an asterisk there, we discovered something interesting. Older, non-Caucasian patients, those with poorer health and lower formal education, were statistically significantly more likely to feel better about the doctor after reading their notes. About 7% of patients reported contacting their doctor about concerns in their notes, and when we looked at the reason for why they contacted their doctor, 29% reported a perceived error, again underscoring the potential safety implications. 85% were satisfied with the resolution. On the doctor side, over half believe that sharing notes increased patient satisfaction and trust. And interestingly, this was oftentimes in a setting where doctors did not know whether patients were reading their notes because they never heard from them. So just the virtue of offering the note had this kind of relational effect from the doctor's perspective. And when we asked about whether OpenNotes caused doctors to order more tests or referrals, 0%, not a single doctor reported doing so. Well, let me just turn to our last topic now on vulnerable populations. I've mentioned a little bit about patients feeling better about the doctor, and that being particularly so for some patients who traditionally fall into more vulnerable groups. Well, we were intrigued by this data, and we went on to ask patients how important are notes to engage in your care, focusing on 5 specific health behaviors. The response category was on a scale of 0 to 10, and we stratified responses by race and education. This survey, again, has 10,000 respondents. Here we're looking at the 7,000 who were adult patients, not including the pediatric hospital. So first we look at understanding how the provider thinks, and these sets of bars, like those that follow, demonstrate that Black patients compared to white and less educated patients compared to those who were more educated were significantly more likely to rate notes as extremely important to understand how the provider thinks. And this pattern was seen repeatedly with making decisions about their care, remembering the care plan, feeling informed about their care, and understanding their health conditions, challenging some baseline assumptions that many folks have about who will most benefit from OpenNotes. So let me round out here by sharing with you some lessons and surprises that we've gathered over the years, over the last 7 or 8 years of practicing in OpenNotes. First is this very issue around challenging assumptions. I think it's easy and understandable for people to think that this is a fantastic intervention for tech-savvy patients. But what we're finding again and again is that there's really universal interest with patients who log on to the computer at the public library in order to access their notes, or matriarchs who are gifted a computer by a family because she has suddenly taken interest in her health. There may, in fact, be unique benefits for more vulnerable populations as our early data is beginning to point towards. OpenNotes has now been used in inpatient settings and even in ICUs, where many people would fear that patients or their families would be overwhelmed by the amount of information. And as we're seeing, OpenNotes may be particularly important for care partners who care for traditionally vulnerable patient populations. Second is this issue of big amnesia, which is universal, extremely common, and part of our everyday healthcare interactions. And despite that these earnest conversations are happening across the country every day in clinic rooms, and many of the key important points or information is misremembered or not remembered at all, it's striking that solutions for this problem are so rare. Data suggests that 40 to 80% of what is said may well be forgotten. And OpenNotes can offer a simple, scalable, and actionable strategy to help patients connect with this vital information. Third is the safety implications, and we've talked through many of these today, and we're excited to see that OpenNotes may help to better connect patients in this space between visits with their providers and their care plan. Finally, number 4, implementation may be a non-event, a term that was used by Kaiser Permanente during their implementation. And across diverse systems, we've really seen a similar experience, that the sky doesn't fall, despite concerns that it might. And in fact, what we've seen here is that skeptics can become proponents, and their voice is often most loudly heard. Here's a last take-home that I'm particularly intrigued by, is this idea that OpenNotes may be a visit extender. And this has really interesting implications about reinforcing messages and next steps. Here's a patient who says, the note gives me step-by-step feedback. It's like having the visit all over again. And the implications for informed consent and for trust, where studies show that for each additional minute spent, trust is increased, or primary care physicians who spend an average of 3 minutes more have lower liability. This can have really big implications. It can also help clinicians make the time that they spend count. Here's a resident who likens OpenNotes to bedside rounding. Rather than spending 30 seconds in the room and an hour outside the room, you can help patients see the time that you're spending thinking about them and their healthcare issues. Extending the visit also cultivates relational effects. Patients read notes and see physical evidence of caring. He really knows me. She really cares. And helps them to take longitudinal ownership over their notes and their healthcare experience. Rather than touching down at episodic visits, they can connect the dots and look at their progress and remember what's happened from one visit to the next, which opens the door to the possibility of notes as treatment and provider presence in patients' journey in healthcare outside of the clinic or hospital walls. And this is the final idea that I'll leave you with, coming back to this idea of the space between visits. I owe this statistic to Sarah Regar, who is a student at the Karolinska Institute in Sweden and also a patient with Parkinson's disease. And she had the insight that for every hour she spends with her doctor, she spends 8,765 on her own, which has led her to take on multiple self-tracking behaviors to better control her health. Well, if you are a safety person, you really care about those 9,000 hours because that's where hazards happen. That's where the delayed diagnosis, the missed abnormal results, and many of the other vexing primary care or ambulatory safety hazards come to be. As this position says, perhaps we overestimate the importance of patients' visits alone. A vast majority of people's time is spent not in the office visit. This is a powerful tool. So let me leave you with some thoughts about why we should share notes. I think the rationale is growing as the evidence base builds. Not only does it improve patient engagement, but we've talked through many aspects of safety that are improved by sharing notes. Satisfaction, patients want it, and I think as Jan demonstrated with the data, they will come to expect it and make decisions about their healthcare centers or doctors based on the availability of notes. That brings us to the business case for OpenNotes. In addition to selecting doctors or systems, this is a major draw for registration on the portal, and we've seen numbers go up significantly when OpenNotes are available. And it is also one of the most used features once patients are on the portal. There are legal rights and HIPAA to consider and a moral basis of doing the right thing. But ultimately, as we talk here as a group who cares about safety, and as a conversation about organizational culture of transparency unfolds in our country, I think the question will not be why share notes, but what is your reason for not sharing? And with that, I will pass back to Jan after thanking the many members of the patient safety team who have contributed to this work.